So let's talk about losing the battle with the yeast syndrome. This is really quite a concern. My concern with the yeast syndrome is that we're succumbing to degenerative disease at an ever rapid rate in this country. Now, if you thought the last lecture was confusing, you're going to love this one. And you can take that either way. You're going to love it because it might be more confusing, because when you try and talk with doctors about this, they don't get it. When you try to talk with patients about it, they always get it. Go figure. So what we'll talk about now is who is or can be suffering with the yeast syndrome, and how someone comes within the vicious grasp of the yeast syndrome, and how to diagnose and treat the yeast syndrome and associated problems. And this is very appropriate for a dental group because you're going to see these kinds of problems constantly, and you can be a major part of the treatment effort with an integrative physician. And then how to stay well after recovery from the yeast syndrome for a healthier future. And this talk is based on my clinical experience treating yeast since 1983, and then this book that I published in 1986, which is still available through Bantam Books. So what on earth are we talking about? Well, it's been called Candida-related complex. You'll notice it's Candida like Canada, not Candida like Candide. So Candida-related complex, or candidiasis, hypersensitivity syndrome, or the Candida syndrome, the yeast connection, that was Dr. Billy Crook's book, the yeast syndrome, my favorite book, the missing diagnosis, that was Dr. Orion Truss's book, chronic systemic candidiasis, or nicknamed the yeasty beasties. And that's the Tower of Babel in the background, you might imagine, with all these different names. It's a little difficult to talk with people about it because nobody's sure what anybody else is saying. However, we can simplify that because the American Academy of Allergy and Immunology has simplified it by saying the concept is speculative and unproven. The basic elements of the syndrome could apply to almost all sick patients at some time. I'm sure they weren't thinking about what they were actually saying when they said that, because they're correct. Not only the basic elements could apply to almost all sick patients at some time, they generally do apply to all sick patients. There's no published proof that Candida albicans is responsible for the syndrome. At least they admit the syndrome exists. Now we're just discussing which of the yeasty beasties is responsible. So they thought that they were being so smart in 1986, they've been wrong ever since. Stephen Barrett, one of the quackbusters, says, "I believe that practitioners who diagnose non-existent yeast problems should have their licenses revoked. Some apply this diagnosis to nearly every patient they see." Well, number one, it doesn't apply to every patient, just 1 out of 3 of the people walking around. So if you say, well, what about those that are walking around come as patients? Usually the healthy ones don't come in, so it's more than 1 out of 3 that it applies to of those who come in. But I would agree with him that practitioners who diagnose non-existent yeast problems should lose their license. But if you diagnose an existing one, I think that you should be congratulated. So you see, I can't agree with the quackbusters. Well, who is or can be suffering with the yeast syndrome? Short answer, anyone. Especially in developed societies, as we fancy ourselves to be, with modern medical and dental care and modern food chains. The animal husbandry and horticulture and food processing and preservation techniques are what are getting us, in addition to the dietary choices of those foods. Everybody recognizes the allergic salute. Watch the kids walking down the aisles at the grocery store. They will salute you right and left. They usually put that little noise with it. Okay? People get ear problems. That's real common, especially in kids. You know, the neat thing about kids is when they've got their ear problems. Let's see if my laser, there we go. Then when they've got these ear problems here, it's always an infection in the middle ear. And I get these wonderful diagnoses that at least I used to hear when I took care of children. Mothers would say that the pediatricians told them it was because the ear tube was too small. And I thought, it was smaller when they were babies. And now they're growing, so how can it be too small now? Or I even had one lady tell me the pediatrician said it was because the tube was too short. And I thought the definition of a tube was it goes from one end to the other. So how could it be too short and still be a tube? In any event, doctors make up all sorts of wonderful things for stuff they don't understand, so you can't fault them. After all, they're doctors. I tell you, if you lock two doctors in a room, they'll come out with 3 opinions. That makes sense. This is cheilitis. That's unfortunate and frustrating. You're going to see that all the time as dentists, especially in people who have dentures. This is just a common feature. And here's sinusitis. You can see in this sinus x-ray it's quite occluded, and that's a very common thing again. Don't forget that people come in with all sorts of things growing all over their tongue, their gums. Here's another cheilitis. Ooh, people stick that out at you and you know they really don't like you. And here, when you're looking down the esophagus, that's yeast growing all over inside the esophagus. That's a view that you only get from being an endoscopist. Oh yeah, that's vaginitis. That's pretty painful. Kids get thrush. Kids get this all over the diaper rash. And that is often the very first situation in which they get it. After that, they can get it as lifelong problems because it's inadequately and stupidly treated, for the most part, by the medical profession. Intertriginous yeast, this is in the skin folds. You can see that it's really uncomfortable. Women come in with this inframammary problem, and that is routinely misdiagnosed and mistreated. They give cortisone creams, they say put cornstarch on it and so on. I don't know how stupid you can get, but there seems to be no limit on that. This is a psoriasis-type plaque, again associated with the yeast syndrome. Here's jock itch. That's not fun. Again, more intertriginous vaginitis, balanitis on the penis. You can see here between the toes what would commonly be called athlete's foot. People walk around with that all the time. Here we see the ungual infection, ratty nail syndrome. Okay, and when people have this onychomycosis, you know, the most wonderful treatment is Lamisil, which is about $900 a series. Takes 2 or more series if it doesn't hurt your liver in the process, but of course it will. Perinechial infections, always when you have a surface change to another surface, whether it's the mucosa on the mouth to the facial skin, whether it's the nail bed with the surrounding periungual tissues. Those are very critical areas. Those are biologically tense areas, and those are susceptible to infection. Again, these can be quite overwhelming infections that people get, and they come in and you go, how long have you lived with this? Well, they've seen doctor after doctor after doctor, and they still have it, which would tell you that the treatment has been inadequate or the diagnosis has been routinely missed. Now, because of this idea that so many people have yeast and you diagnose it, some people say, I'm just a one-trick pony. And indeed, it sounds like that, except for the fact, if this trick explains most everything, why not treat it and then see what's left over? So, unfortunately, a lot of people make the assertion that, you know, oh, well, it can't all be that, and the question is, but what if it is? So, the other question comes down to, well, if it's not all that, then how's what you're doing working for you? Because if you're still having problems, somehow we better look in a different avenue. What I've said is that in the past, knowing syphilis or TB meant knowing the breadth and depth of medical diagnosis and treatment. Today, the same has been said about AIDS, HIV, but in fact, the yeast syndrome is the greatest and the most often missed masquerader, the unsuspected root of many, perhaps even most, distressing symptoms. Proper evaluation and treatment can avoid most drug and surgical treatments, avoid most drug and surgical treatments for up to 2 out of 3 Americans. Abram Hoffer, who wrote the introduction to my book, said, polysystemic chronic candidiasis is the new yet old generalized fungus infestation responsible for a vast number of diverse physical, mental, got that, and emotional disorders, because this is the era of, not feeling quite right and needing all these fancy drugs for your brain. Who would have dreamed that a seemingly innocent yeast-like organism, Candida albicans, could be the cause of so much misery to the patient, even to the point of stimulating thinking about shortening one's time on earth? These people get desperately depressed at not getting better. Finally, we know the truth about the chronic yeast infections. The yeast syndrome may be the most important book of this decade. Candida albicans, very innocent-looking little yeast bug, little balls. They form in longer chains as well. The filamentous form of the chains. and that allows them to move from one area to another. Make them uncomfortable, they will all chain up and go elsewhere. The significance to human health cannot be overestimated. The discomforts are common. Overwhelming systemic infections are uncommon. And that's where the doctors say, oh, well, you can't have yeast because you'd be dead if you had yeast. They don't understand the infection process and where this is centered. It's not floating around in your bloodstream. Unfortunately, some of the people who use live cell analysis see all these yeasties floating around in there. If those were there, you'd have yeast endocarditis. You would be dead man walking. And that's not generally the case. Concomitant infections, however, are common. And those infections are very confusing because which are you dealing with? This or the yeast, or that or the yeast? And unfortunately, lots of concomitant infections often occur in the same patient, especially if they're immunocompromised. Nutritional deficiencies and toxic exposures amplify the yeast syndrome, and those, of course, are increasingly common in our society. And that's part of how someone comes within the vicious grasp of the yeast syndrome, because you see, in the context of modern TV-based lifestyles, we are urged to use chronic allergy medications. Oh, just once a day, because this one lasts 24 hours. Chronic steroid applications, because you want comfort, don't you? Just use this cream. Chronic antacids and acid inhibitors, because God made a mistake and gave you too much stomach acid. Chronic anti-inflammatories. Chronic anti-yeast topical applications. They're over the counter now. You know, you kind of get the idea that we go to anti-doctors because they have an anti-something for everything. How about insistent demands for the latest prescription medications? You know that famous phrase, ask your doctor if blah blah is right for you. Okay, I must be going to a stupid doctor, because if that would be right for me, wouldn't it cross his mind or her mind? Wouldn't they say, got just the thing for you? Why would I have to ask them? Well, maybe I should just be the doctor, because I don't think we do any worse. There are countries where a lot of this stuff is over the counter. I don't think they're doing worse. And how about chronic dietary compromises, the sugars and starches, the yeast-dependent foods? You know, there are people who can't do without their breads, their wine, their cheese. Those are used, you know, yeast is used in making those foods, and yeast tastes good, let's face it. Fried foods, processed, preserved, adulterated, and empty-calorie foods. How about the usual context of medical care? The predispositions are common for developing the yeast syndrome. Diabetes and metabolic syndrome, persisting infections, frustrating chronic constitutional complaints and symptoms. What that means is you go to the doctor, I don't feel well. Anything hurt? Nope. How do you mean you don't feel well? Don't feel well. I'm tired. Well, you must have thyroid disease. Well, we tried that. I'm on thyroid. It's okay. I don't feel well. Those are very frustrating chronic constitutional complaints. Where do you start? It's not like saying my elbow hurts, so we take an x-ray of your elbow. Those things lead patients to getting on more and more medications, especially the psychiatric ones. We'll help you feel well if it kills you, or if we kill you. Fertility and PMS and menopause and performance problems. Geez, the whole world must have performance problems because we see all those advertisements in the bathtubs. How about organ failure? Incidentally, when is the time right for you? When she says it's right, when he says it's right, when we look at each other and it's right? Good grief. Yeah, exactly. That is the only time when it's right, actually. If mama ain't happy, ain't nobody happy. Yeah. Don't you wonder that this is the topic of public advertising? I mean, good God, what have we come to? Organ failure patterns, liver, kidney, lungs, heart. These things are increasing. I mean, you know, we have routine transplants going on everywhere now. Dietary choices are always the problem, because if you ask your doctor, you're doing just fine. Just stay away from all those fats, eat margarine, not butter. How about airborne pollutants and allergens? Ooh, try getting away from those. Very simply, the predisposing risk factors for the yeast syndrome can be summarized by A, B, C, D, and then added to by E, F, G, H. Antibiotics came about really in the 1950s. Birth control pills came about in the 1950s. Cortisone-type drugs came about in the 1950s. Deplorable diet. Well, you remember when there was just one McDonald's? Okay. And now, you know, 25% of the American food dollar goes to fast foods or quick-serve restaurants. 25% of that goes to McDonald's. So 6% of the American food dollar is spent at McDonald's. And you go to yourself, all that's happened since about the 1950s. So can you see how this block of concerns right here, A, B, C, D, is all a very recent invention, which would make predisposition for the yeast syndrome a very recent problem, kind of like the obesity and diabetes pictures that I showed you over the last 20 years. But we can add to that the environmental toxins, since we decided to poison the planet in the last 60 years, our full of stress lifestyles. You remember back in the Leave It to Beaver days, it used to be much more casual and kind of much more fun, and Ozzie and Harriet had time to listen to their son play guitar and sing songs. We don't have time like that because we're into heavy metal and rap. Who knows what the rapper's saying, all that stuff, right? Okay. All that just seems to me like much more stressful than listening to Chopin or Bach or Beethoven or Mozart. Genetic differences help outline the yeast syndrome. People who have certain predispositions are always going to have those. They came wired with them. The problem is not the genes. The problem is what accommodation do you have to make to wire around those deficiencies associated with the genes. And of course, most of those changes will be in the health habits. We use alarm clocks now because we have to get up early after having stayed up late. In the old days, didn't have to worry about that. The chicken woke you up and you went out and did the chores. You went to bed when it got dark. Now we use lights to stay up all night. We have to listen to Fox News. We have to listen to CNN. We have to do this and that. And then we have to get ready for tomorrow. And pretty soon our health habits show us that we are not taking care of ourselves. But we're certainly leading our lives. And I always question, what does the term leading mean then? How do you diagnose and treat the yeast syndrome? Well, how much does the chief complaint matter? Because, that's what we're taught in medical school. I'm sure you guys are, well, where does it hurt? Hurts right here. Okay, we're going to focus your initial attention right there to find out what's going on, because you certainly have to fix whatever they come in with. You might find other problems, but you have to address the chief complaint. Well, here's how much it matters. Doesn't matter. Not at all. It's irrelevant. The only reason the chief complaint matters is that they showed up. Whatever it was, that got them into the office. That got them in for care. That got them in so that you can pay attention to what's going on in their body so that you can work on fixing their health. That's all that matters. And here's the deal. A thorough clinical history is always the key to diagnosis. And the reason that doctors don't get the diagnosis is because they don't get the history. And the reason they don't get the history is they don't have time. They're too busy taking care of patients. And if you have to keep, as Dr. Gutman says, you just want to show up, not be disturbed, get through the day, and go home. Well, patients who want to pester you with information are disturbing at best, okay? And they always set your schedule back and such like that, and especially because when do you have enough information? When can you safely stop taking the initial history? How many marbles or jelly beans do you have to gather in this? Well, enough that you feel really comfortable as a physician to answer what's going on with that patient in a way where you can start planning a treatment that is likely to work for them. Likely to work. Not just a treatment, but one that's likely to work for them. So diagnosis is made in the face of confusing, overlapping, and unrelated symptoms. That's why you have to listen to them. That's why you have to get a lot of history. We have simplified that in my office because it takes 6 hours to fill out the forms to get in as a patient. And we get folks who show up and go, well, I'll go ahead and finish that after I talk to the doctor, or I'll just talk to the doctor about mine. And the answer is, you won't ever see the doctor. This is a very efficient way for me to spend my time talking with you only about what is important for your health. Been doing this a long time. I can get to that answer very quickly. I want to spend all my time talking with you about you, not just going through nope, 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 nope. And because of these confusing and overlapping and unrelated symptoms, it gets important to figure out what is important in the middle of it. You got to find the exceptions. What are the things that make this particular patient unique? And that's why those forms, because then I can very quickly begin to see the patterns emerge from the background, which isn't always easy. And remember, the patients have not read the book. They do not come in saying, I have this, this, and this. They come in and saying, well, and then I got that, and then I saw this doctor, and then Aunt Louise said this. It's just noise. I'm after signal. I'm after really seeing clearly what's going on in the picture. And confirming the diagnosis is best done by a therapeutic trial, although the anti-candida antibody testing might prove useful. Now, when I say a therapeutic trial, once you formulated that this patient actually has yeast, how would it be easy for you guys to see they have yeast? Well, gosh, it's written all over their face and their mouth. Okay, that makes it easy. I mean, dentists got a leg up because doctors never look at a patient. I can stop right there. Doctors never look at a patient. They say, hello, Mrs. Smith. They're down at the chart. They order the x-ray. Goodbye, Mrs. Smith. Because see, I ask patients, I do orthopedic medicine, and I say, when the doctor examined your shoulder, what did he say? Well, he never touched my shoulder. No, I mean when he twisted it back like this. He never touched my shoulder. Well, what did he do? He ordered an MRI. Well, what did he say about your x-rays? He never got an x-ray. Well, who got the x-rays? No one ever got any x-rays. They just got an MRI. Well, pretty soon you realize doctors aren't treating patients. They're treating tests. So the deal is a therapeutic trial means you have to treat patients. You have to give them a treatment you think will work and then assess were you close to correct. The anti-candida testing might be useful, but the patterns could be confusing. So I apologize that this has words on it, but we'll go through them. If you have high IgM, IgG, and IgA, it's a no-brainer. Oh my gosh, this person has the yeast syndrome. But what if you have IgM and equivocal changes on A and G? Well, it could be that this is a new infection and you're just mounting the kitchen sink immune response. What if you have equivocal IgM but high IgG? Looks like it's a long-standing infection, and especially if the IgA is elevated, it's a long-standing infection on a surface membrane, whether that's bladder or lungs, sinuses, vagina, mouth, whatever. It's on a surface membrane. Now, IgM equivocal, IgG equivocal, IgA equivocal. Looks like the yeast syndrome, but it could be normal. What about if these are all three are low? Well, it could be normal, but it could be you have the yeast syndrome and you just gave up. Your immune system is exhausted and won't mount a response. So that's why I say that the testing might be useful. It's useful in one situation, when it's a no-brainer. The rest of the time, it's just medical legal. Yes, I checked for it and I interpreted the test this way, but that's about it. If it's a no-brainer, you win. But the therapeutic trial is continued until both the patient and the doctor are convinced that the yeast syndrome is the problem or it isn't. And that's just kind of a clinical thing. This is where clinical medicine becomes the art. The comorbid conditions often lead to diagnostic confusion, largely because canditoxins affect so many different physiologic functions. Canditoxins, that sounds poisonous. Back in the 1980s, we knew that there were at least 20 of them. The Japanese did in vitro in the glass test tube studies and showed that these toxins were elaborated or produced by the yeast and affected amino acids, sugars, fats, vitamins, minerals, hormones, neurotransmitters, blah, 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 blah. Just keep going on the list because they can affect all of those things. We now know there's over 60 of those canditoxins. And what's interesting is if you stop and think, there are three kingdoms: the plant kingdom, the animal kingdom, and the fungus kingdom. Now, the plant kingdom takes sunlight and makes energy fixed in the leaves and fruits of the plant. The animal kingdom eats the plants and other animals that have eaten plants. The fungus kingdom eats the other two, the plants and the animals. And this is why when you walk through the forest, you see the fungus, the mushrooms, and so on, growing on dead and dying trees, piles of leaves, and so on. So if you see it growing on you, dead or dying, not dead yet, must be dying. And indeed, that's the whole point. Yeast grows on susceptible individuals, ones who have lost the ability to control the yeast growth. So that what happens is you are now victim to the yeast, and it is putting out poisons that damage more and more and more of your biological systems. Your amino acids, sugars, fats, vitamins, minerals, and so on, which further disables you, which means you are now closer to dying, which means you are better to be recycled by the yeast, which means they'll put out more canditoxins. Can you see how that's a downhill? And that looks like the treatment of chronic disease in this country, doesn't it? Well, this country, probably Canada too. Comorbid conditions are further confusing because the yeast syndrome can develop as an opportunistic infection whenever the clinical setting favors yeast growth, especially with diabetes, metabolic syndrome, obesity, immune compromise, and so on. So comorbidity is really the watchword of the day because this is what confuses everything. So explaining to the patient is often the most important first step in gaining compliance with a complicated treatment program. You are about to see the complication, but I will explain to you a very simple way to make patients understand it. If you have a lawn and you have a few pesky weeds growing in it, do you get excited? The answer is no. You might even be motivated to get off the porch, go over and pick some of those weeds, pull them out, let them dry in the sun, spray some nasty chemical on them or so on, but you don't get too excited. It's only when you start getting more and more weeds, and then the weeds are really taking over the grass, now you're excited, now you're going to go get some weed and kill, or I don't know, whatever it is, and do something about those pesky weeds growing on the lawn. Same thing inside you. If you have a few yeast growing, it's no big deal because those are commensals. Those are things that go along with the fact that you're alive. There are normal natural flora in your gut. There are normal natural flora on your skin. And this is why doctors miss it, because remember, doctors are treating tests, not people. So when they get the test back, they say, yeast, fine, normal, and go on. Except for the fact that they may well be missing a higher than normal concentration of yeast growing, especially in your gut, because that's the toxic waste dump that most often you are being taken advantage of. That's where the yeast is growing most out of control. So once patients understand that the reason other doctors miss the diagnosis is because they make assumptions about what's normal, and we're making assumptions that that's abnormal, and if our treatment works, then probably we're more right than that other stuff that didn't work. And they go, okay, well, I'll give that a try. So the complexity and duration of the treatment relates to the age of the patient. Little kids get better much faster. The sex of the patient. Men get better faster than women because women have a much more complex biochemistry. Comorbid conditions, including how well they are nutritionally, what kind of toxic exposures they have, how well their lifestyle has worked, the extent of the yeast involvement already, and most important, compliance. Compliance is the key. Treatment planning is initially based on the most significant problems, both in the patient's mind, their complaints, and in the physician's assessment, their conditions. Because you've got to address what bugs them most. What they came in with are what I call target symptoms. They want this fixed. Well, don't fix that last. It really helps if you fix that early on, and then they're much more willing to go on with the rest of a treatment program. Same thing in dentistry. The physician's assessment of conditions is where you've got something you've got to do something about because it's going to get worse and in an unpleasant way, and you address those things early on. Suzuki says our tendency is to be interested in something that is growing in the garden, not in the bare soil itself. But if you want to have a good harvest, the most important thing is to make the soil rich and cultivate it well. That means that you've got to change the terrain of the patient. You have to change the physiology of the patient in order for a treatment program to be effective. And when we talk about effective treatment program, dietary compliance is the sine qua non of successful treatment. No compliance, no successful treatment. Little compliance, marginally successful treatment. Patients who really get the program, do it, get better. Patients who don't, and don't. So the idea is to tell them when they need to stop doing the program. Why don't you wait till after the holidays? Why don't you wait until after your vacation? Why don't you wait till after the family has visited and you've gone off for the birth of your grandchild or whatever, and come back where you can make a stable attempt at it? Phase 1 is called the MEVI diet. Meats, eggs, vegetables, and yogurt, heavy on the vegetables. But the meats and eggs are just fine. The yogurt is just fine. It's a low-carb program with a low allergy potential. The carbohydrates of concern are sugars. Now, starches, as you know, are just sugars holding hands. Your body takes scissors to that, bingo, and you've got sugars. Sugars release the neurotransmitter dopamine, and that's the addictive mediator for cocaine and other addictive substances and behaviors. Sugars are tasty, legal, and highly profitable. Sugars control our lives because we've surrendered to them. The dietary recommendations can be modified to accommodate vegetarian lifestyles, blood groups, eat right for your blood type, food allergies that are known and unknown, because you can help people diagnose those, gluten or lactose intolerance, endomorphic habitus, that's, super skinny folks and so on. And, the whole point of doing this is to personalize the care for the patient. So the initial nutritional supplements will be based on obvious need, patient symptoms, and specific choices that are needed for treating the yeast syndrome. And so we have sort of our general strategy that we start with and adapt it to patients as we need to change it. Now, the anti-yeast nutritional supplements are essential to minimize iatrogenic discomforts. In other words, we're going to make them feel worse when we do this treatment program. We're going to provoke things and to prepare for more definitive treatment. And the more definitive treatment is going to follow a course of undesolenic acid or caprylic or garlic or oregano or other things that specifically help squeeze the yeast. We're trying to carefully, gently restrict and control the yeast growth so that when we actually go use a more important treatment program, that program will not be a disaster for the patient. Oh, I might add why I had developed this program. I started treating this in 1983. I was terribly excited. I had none of this printed stuff. Dr. Crook's book wasn't out yet. Excuse me. And what I had to do was explain to patients how this worked and how excited I was. And this is going to be great. And fully 1 out of 3 patients did not make the second or third visit back to the office. Well, when you're excited and you know you're right and those patients can get better, you call them and you say, "Ho, where are you at?" And they go, Hey, I only thought I was sick before I visited you. I'm never going to feel that bad again. So you go, okay, that sounds bad. Well, what was known was the Jarisch-Herxheimer reaction, which we'll talk about. So I had to develop a way to squeeze more gently to introduce people into the dietary program. The medications, not yet. Now, patients will want to rush forward and get better, especially they read the book, they've talked to people, and they know about it, and they just want to get treated now. No. Patient insistence and physician impulse to make people better now have to be resisted. And sometimes it's hard, and sometimes I even kind of cave in and put people on a program just before they're ready, and you have to backtrack and just say, "Stop everything, we'll fix it, don't worry about it." You have to give them the constant reassurance. There's the Jarisch-Herxheimer reaction. That looks like an orange that has just been shot, and that's what patients feel like when they get that. What that amounts to is if you have a sponge and you squeeze it gently, you will have toxins flowing out. Okay, like water comes out, it acts like yeast toxins, whatever. If you take a sledgehammer to the sponge, you will splatter that stuff all over, looking very much like this Herxheimer reaction here. Now, when that splatters all over, your patient feels miserable. These are the yeast toxins and proteins and such that were starting to make them sicker and sicker as the yeast was growing and percolating that stuff out. But as you amplify this suddenly, they really get ill. Now, this is a short-lived period of time. Explain that to the patient who doesn't believe he's got much longer to live. And we're serious about this. You got to keep a sane patient because they just feel like they are going to die. So we use proteolytic enzymes and hydration as part of our tricks on that. They've just got to get enough fluids in. They've got to take the proteolytic switch, in our estimation, chew up those yeast toxins and proteins and such. And ascorbic acid, to the extent we can get them to take it, will also help to nullify some of that. Then you do further testing as appropriate: digestive function, nutritional sufficiency, toxic exposures, hormonal adequacy, others that are indicated for that particular patient, because this is a holistic approach. Fail to treat the whole patient, you will not get the whole patient better. And whatever you leave leftovers, they will be unhappy. You've seen this slide before. We're talking about appropriate acid in the stomach, appropriate buffering in the intestine, making sure that leaky gut problems are not affecting the cells, the absorptive cells in the gut, and making sure that you've got appropriate gut biosis. In other words, that the bacteria that we walk around with are appropriately balanced for our body. Now, probiotics are absolutely essential because our internal ecology, which is an evolving relationship we have with our gut flora. It's never constant. It's always changing, reflecting our conditions. Might be the key to understanding, not just having the yeast syndrome, but also many of the other puzzling degenerative diseases probably relate to the gut flora. Remember, we've talked about inflammation. I think that gut dysbiosis is one of the first keys and one of the remaining ones for the inflammatory patterns going on inside. That's the gut bacteria. If you don't control that, I don't care what disease you're treating, you don't get better. Further nutritional supplements, as indicated by the history, the exam, or concerns for the doctor, or by test results, is needed to assist with comorbid conditions. Again, remember, car has 5 wheels. Tell a patient, you realize a car has 5 wheels? And they go, 4. And you go, and the steering wheel? Oh, 5. Because what you've got to get them to see is that which one you fix first is irrelevant. You've got to fix all 5. They've all 5 got to be working for the car to work. So you're going to have to pay attention to the gut. You're going to have to pay attention to this. You're going to have to pay attention to that. You outline the concerns you have for that particular patient, and they go, oh, okay, I get it. Because no doctor has ever done that kind of comprehensive pattern for them before, which is why nothing has ever completely worked before. Now, let's get to medications. This is where patients want to go. This is where they expect to go when they come in. Nizoral, nystatin, these are the kinds of drugs that are most commonly used, and I think with greatest success. There are others. The mechanisms of action matter, so I call them shockers, bleeders, and blockers. The shockers disrupt the cell wall in such a way that the bug explodes. The bleeders disrupt the cell wall in such a way that they literally bleed to death. They ooze out their contents. The blockers inhibit making of the cell wall, and that stunts their growth. So, the idea is to find the right combination of shockers, bleeders, and blockers. And so nystatin is a polyene that helps to explode the yeast. Now, there's a little problem with that. Remember I talked about that sponge? And if you hit it with a sledgehammer and everything explodes, you don't want to do that right off. This is considered unpleasant by the patient. That's the Jarisch-Herxheimer reaction. So what we use first is bleeders to help them ooze to death. Nizoral being my particular favorite, but you can use others. And in a low dose, nystatin will also work as a bleeder. It's unusual to use the blockers, which help stunt the growth, because those are just much more unusual drugs and with more side effects. So when you talk about the, excuse me, the azoles, the bleeders, these are synthetic compounds that have 2 or 3 nitrogen in their ring, all the biochemistry that you never want to know. The primary action is to interfere with the cell membrane so that they start to ooze and bleed to death. Cell death results, but in a slow pattern, not a rapid one. So the most common ones would be Nizoral and diflucan, and those have slight differences in their mechanisms of action. There are some newer ones you can use only in patients who have much more sophisticated illness problems and are not getting better. The bleeders, Monostat, Nizoral, diflucan, Lotrimin, Miselex, names that you might have heard in the advertisements on TV, in the medical literature, whatever. Imidazoles are very valuable. There are also some topical ones that you can use, and for the oropharyngeal patterns, this is extremely useful. So, and it's extensively used to treat the common and uncomplicated forms of candidiasis. Now, candidiasis is not the yeast syndrome. The yeast syndrome comes when those weeds grow out of balance and begin to affect the biochemistry inside you in such a way that you cannot protect yourself. The topical ones, when you get a little thing here and there, no big deal, just take care of it with the simple topicals like Miselex or Lotrimin or Monostat and so on. The shockers, the polyenes, these are broad spectrum things. They insert into the fungal cytoplasmic membrane. They increase the permeability, and the membrane channel activity goes crazy, and these folks start to bleed and then explode, and that would include amphotericin B, rarely used, but would also include nystatin, which is the most commonly used. This is the classic fungicidal one. It also has, as I said, fungistatic effects. So you've got lots of treatment options. This is where the art of treating this comes in. But the deal is changes to the permeability of the fungal membrane after it is bound with the nystatin leads to cellular component leakage. And that's the key. You've got to control these in a nice, simple way to make things die. We won't deal with the blockers, again, because they are so rare in terms of clinical usage, but I included them here so that you have them completely listed. So what works for most people? Nutritional yeast suppressive agents briefly. In other words, nutritional things that help control yeast growth. You're getting the patient ready for the medications. Then an azole briefly, such as Nizoral, and then add nystatin pure oral powder prescription continuously. The objective here is to lead into a control pattern without exploding the way the patient feels. Now, nystatin, there's nothing magic about the name. It came from New York State, where it was discovered in a barnyard, and you want to resist falling victim to the Texas Ranger theory of medicine. Oh, well, they've got yeast treated with nystatin. Oh, well, they've got yeast treated with Nizoral. This is a complicated treatment program that deserves planning, because otherwise you'll have the patients drop out the same way that I did. As you remember the Texas Ranger theory of medicine, one drug for one disease. One problem, do this. One problem, do that. Everybody wants to do cookbook medicine. Unfortunately, the recipe that you're working with is a patient who doesn't come looking just like every other patient. Follow-up visits are used to assess and minimize the symptoms associated with treatment. Very important. Get the patient's complaints, because those are related to compliance. Once you figure out what it is that will keep them from complying, you can help make that happen easier. You evaluate the patient progress, encourage the compliance, and plan and promote an evolving treatment program. They want to hear that they're getting better. So the first office visit that we do is we recommend reading for them to do and start counseling them about a dietary program and supplements to take. See them back in 2 to 4 weeks and start a treatment progression with the medications. And an office visit then 4 to 6 weeks, 6 to 8 weeks, and then eventually you're seeing them every few months to finish off the treatment program. They are classically getting dramatically better during this time frame. If you've established a good relationship with the patient, they will let you know if they're not doing well, and you can often just counsel on the phone. Try this, do that. The dietary concept, fresh, whole, and raw, is always better. The phase 1 eating is low carbohydrate. The phase 2 adds more starches. Phase 3 adds more sugars and those foods with a higher allergy potential. And phase 4 is intense sugars, actual sugar products themselves, those with a higher allergy potential, and yeast-dependent foods such as soy and vinegar. All these are described in the yeast syndrome book, so I won't give you details other than the general broad sweep, but the dietary advances will be the foremost question in the minds of patients. They would like to eat more foods. I would like to eat walnuts and prunes. Okay, well, maybe yes on the walnuts, no on the prunes, that kind of thing. They are uniquely dependent on symptom control. In other words, the better the patient is complying, the better symptom control they get, the more you can advance their foods. And they are uniquely related to patient compliance. Sometimes you just give in and just know you're going to treat the patient longer, but they'll be happier. So you start with phase 1. As they're doing better, you add 1 item daily from phase 2, and then 2 items a day, and then 3 items a day. Eventually you're rotating the foods and food additions and getting to the point where they're eating phase 1, and then some additions, and then phases 1 and 2, and then some additions, and then phases 1, 2, and 3. It's rare to have a whole lot of phase 4 foods because these are still sick patients. They still need recovery. The follow-up testing is as indicated by the patient's complaints and concerns. Remember, we're dealing with things that have comorbid conditions as well. The test results that you get, I will often see patients who come up with positive rheumatoid tests, positive ANA. And I go, tell you what, this might just be that your immune system is ticked off at you. That's part of the inflammation pattern, part of the infection pattern. Why don't we wait and watch? Often these things just go away. Comorbid conditions are extremely important because, this is called the 3-tack theory of medicine. If you're sitting on 3 tacks complaining of a pain in your butt, I find and remove 2 of them. You don't say, thank you so much for helping me by reducing my pains by 2/3. You say, I still have a pain in the butt. So we've got to get all 3 tacks, just like all 5 wheels on the car. So treating the comorbid conditions matters. And that's why health enhancement is the ultimate goal. You don't just want to control yeast, you want to fix the patient's problems. So the progress of recovery is from initial symptom complaints to careful goal setting associated with treatment and compliance so that people understand what they're doing and why, and address their new evolving concerns and encourage, ultimately, health enhancement. because that's really how to stay well after recovering from the yeast syndrome for a healthier future. So long-term planning involves resolving all these concerns and complaints, promoting the healthy lifestyle habits, reducing the prescription dependence. These people come in, they're on a dozen drugs. This one for that one for that, this one to control the side effects of that one, this one because the other doctor said maybe I had it, and half of them are on psychiatric drugs. That should tell you something. You want to reduce the conventional physician and drug dependence. You know, they're dependent on their physicians just as well as on their drugs. I've got to go see the doctor. And you want to encourage health enhancement. Incidentally, it's called the medical merry-go-round. When you have yeast, if you've got a specialist for everything, you got yeast. Most symptoms are treatable. Most illnesses are soluble. Health can be enhanced. Patients are trainable, contrary to what you've heard. I don't know if you've heard that, but they are trainable. And reassurance and education are the most valuable physician tools. A great staff to counsel patients really makes a difference as well. Now, you have to fix their remaining problems. These folks have become very resigned to their suffering. Their doctors have said, well, there's nothing we can really do about it. Well, you know, a doctor said that. Like I care. I do a lot of whoopee. I go, yep, I get it. Whoopee. All right, I don't care what they said. Because it's irrelevant. You know, how did that work for you? Earlier adoption of health habits matters. Reduction of obvious age-specific or sex-specific conditions matters. Reducing patient-specific complaints or risk factors matters. And then you want to make sure that you do not miss mortality-associated diseases. If these folks are coming down with issues such as diabetes and such that can be much more related to mortality, don't minimize those while you're treating the yeast syndrome. So lifestyle changes, I have listed a whole bunch of things on here. One thing I want to draw your attention to is the MSG and artificial flavorings, preservatives, food chemicals. Those are absolutely critical and may well be part of the genesis of inflammation patterns inside our systems. On the bottom, you'll note I said restore gut function. The fact that it's on the bottom does not mean it's the least important. It may actually be the most important. Maintaining long-term health. Dental restoration technologies matter. If you walk around with continuing mercury in your mouth, you are constantly seeding more poison to encourage further problems. If you have yeast in your gut and mercury that you swallow, the yeast will convert that organic mercury to methyl mercury, which is far more toxic. So why don't we, as long as we're treating the yeast, why don't we encourage that they get their silver fillings out, because that mercury is deadly. Drug-drug interactions, we have to pay attention to things like the cytochrome P450 system you are going to hear more and more about, because doctors finally discovered that that actually exists. And there's things that interfere with it. I'll give you an example. Patients who eat grapefruit every day interfere with their P450 system. And that changes a lot of balance on the inside. So what you want to do is just counsel patients about things that they should do on a more occasional or as a treat basis rather than other things. Now, drug-nutrient interactions, well, you know, drugs are deadly for nutrients, and you've got to make sure that you're replacing those. I'll give you a good example, a simple example. Diuretics just waste your B complex and your magnesium like crazy. So if you're not replacing those, if patients don't know it, then they just get worse with problems such as high blood pressure, heart disease, and so on. How about drug physiology interactions, like statins interfering with CoQ10? How about hormones and vitamins that are associated with essential fatty acids? Vitamins and bile acid salts. You know, the whole point of eating food is to digest it, but if you have to have your little purple pill every day, you are not going to do well with digesting your foods. And then the drug effects that we talk about, hypochlorhydria due to the over-the-counter prescription blockers and so on. You know, it's very interesting that they have so many over-the-counter things, the cortisones, the yeast treatment, the acid blockers and such, because pretty soon everybody will be able to insist that they have chronic disease because they have to have their over-the-counter treatments. Anytime they have to have something, you need to know about it. Stealth pathogens are going to have an increasingly important role, especially parasites, and I don't want to leave out prions because I think we're going to start finding more and more disease problems associated with, confusing presentations. As we actually start applying technology to understanding some of these diseases, we're going to see more and more that infections and pathogens are really a major problem. Gingivitis, a chronic persistent bacterial infection. I think that's important, and that may be part of the MRSA picture, because what we've got is this chronic imbalance with bacteria that are affecting the way we work from the get-go. I think those matter, just like the nutritional deficiencies matter, just like the chronic drug exposures, the ibuprofen, the diet drugs, the stimulants and antacids and blockers, and so on. Long-term health depends on hormonal balances, thyroid being, I think, one of the most important because nothing else works right if thyroid don't work right, the pesticides and preservatives in our diets, and how about genetically modified foods? We're starting to see more and more of those hit the market now. You know, maybe if you eat genetically modified foods, you get genetically modified people. That's a thought. What about fluorine and chlorine? I think the two largest public health experiments of our time. I say experiments because nobody's proven them safe. In fact, there are some questions. Kind of like putting mercury fillings in your mouth. Another wonderful public health experiment. Except that now we know that's not safe. It's just some of the dentists don't know it yet. How about inflammatory challenges from chemicals and toxic metals and such, and of course the dietary excesses from soy and the phytoestrogens in our foods that are changing things. Maintaining long-term health talks about chemicals because we're exposed to them. You know, there's more chemicals in the counter or the cabinet underneath your kitchen sink than there were in the standard chemistry lab in 1900. Just look at the list of chemicals down there. Air pollution is from ambient air, from HVAC systems, electromagnetic radiation, a serious problem, totally ignored by most physicians and by lots of integrative physicians. Magnetic disruptions, I think, are increasingly important because nobody's really concerned about a waning magnetic field. We've got serious issues going on this planet, and we're more concerned about greenhouse gases and global warming, which might not exist. Well, the greenhouse gases do. I'm not sure about the global warming. Stress patterns, factors X because I don't know all the stuff. But maybe we ought to start looking at more and more of the factors because, you know, some of the simple things really matter, like personal hygiene and grooming practices, like, you know, brushing your teeth and maybe flossing or using a water pick or so on. Sexual practices, you know, it's alarming the spread of sexually transmitted diseases because you don't need to worry about condoms. You're not worried about getting pregnant. Yeah, but there's other things. Exercise habits, blood oxygenation. I talked with you about doing research on oxygen patterns. There's just more and more people who are showing up with low oxygen level, and how do you make defense system bullets without oxygen? Genetic predispositions and gestational issues and postnatal issues. You know, isn't it fascinating that God gave women breasts in order to feed babies, and then we use formula? That's that God again that just keeps doing all sorts of unnecessary things. Too much acid, too much cholesterol, too much blood pressure, and breasts. Okay. Is the yeast syndrome resistant to treatment? I think basically no. You know, the idea is that people go, well, I didn't get better, I was treated for that before. Well, it depends on the elegance of the doctor treating it. Okay? It's kind of like doing dental work. Depends on the experience, expertise, and skill of the dentist doing it and how well you take care of it. I think the real keys to the kingdom are we have to reduce the infections, reduce inflammation, recover immune function, and recover gut function. And again, because I placed it at the bottom, has nothing to do with nothing, because indeed, gut function is the key to the kingdom. The thyroid connections matter. Restore gut function when you're treating thyroid disease. How many doctors who are writing for Synthroid, which I think is a bad treatment, are actually worrying about restoring gut function? This is one of the first glands interfered with by yeast toxins. Sinusitis strategies. I want to just share with you. This is the focus for persistent infections or recurrent yeast syndrome. Everybody's got some level of sinus problem, especially with the yeast syndrome. These things live in these pockets right in here. They're very happy. I've listed a whole bunch of strategies. These do include, I've left out, you know, the nystatin, the phase 1 and 2, and eating and stuff like that. But Nizoral is absolutely essential because it gets into the fluids in your sinuses and comes out and directly kills yeast in there in a way that you can't get nystatin onto the surface. And then, of course, restoring gut function. How about recurrent bronchitis? A lot of people are suffering with that. Again, Nizoral, very important because you can actually get it into the secretions in the lungs, as well as restoring gut function. I'm assuming that people are not smoking and minimizing other exposures and so on. Don't you love these asthma commercials on TV? This guy is helping his son sand his boat. Sanding, dust, exposure to, anyway, whatever. GERD and reflux and heartburn, the illness of our times, chronic esophagitis. You can use Carafate to help heal those problems. Miselex oral troches dissolve down to kind of quietly kill yeast in the esophagus. Nizoral, important again to use to treat yeast from the inside, from the solutions that are produced by our body. And again, restore gut function. We take care of almost everybody with heartburn. Diverticulitis. I haven't hospitalized a patient since 1984 when I came up with the idea, wait a minute, if you treat with Nizoral for extended period of time, normalize gut function, use adequate antibiotics when you're treating with Nizoral, you know what? They don't get diverticulitis anymore. And if they do, you go ahead and retreat them. Prostatitis, same thing. Nizoral, restore gut function. Again, this is not just these one-trick ponies. It's the whole treatment program, but making sure that you include the Nizoral. Pyelonephritis. I used to hospitalize patients all the time. I trained in urological surgery. They come in with 106-degree fever. You treat them for their pyelonephritis. They're back in 4 to 6 months. They have it again. Guess what? Studies done by Carlson back in 1980, reported in 85, showed that every species in which they injected yeast and bacteria into the peritoneal cavity of these animals, every single animal showed yeast balls in the kidneys. Now, they were also elsewhere, but they were always in the kidneys too. And guess what was growing inside the yeast balls? Little bacteria nests. So until you kill the yeast, you never get to the bacteria. So the recurrent infection was one that you never treated to begin with. You never got to it. I stopped having to hospitalize patients recurrently for pyelonephritis just by changing this treatment strategy. How about MRSA strategies? People come in with all these, I've got MRSA, I have to have all these nasty drugs and stuff. No. Sorry, not necessary. How about if we just get your immune system working better? And that means get the yeast out of the way and restore gut function and so on. Memory, concentration, anxiety, panic, depression, these are pandemic in our modern societies. And guess what? They're amplified by toxic chemicals and toxic heavy metals. You need to do nutritional support as indicated. Who remembers a wonderful book called Mental and Elemental Nutrients? This goes back 40 years. This kind of stuff is so absolutely critically important that we've ignored the idea that nutritional deficiencies amplify the effects of toxic metals and chemicals. Again, oh my gosh, restore gut function. This is where your inflammation is coming from, guys. The vast majority of your immune system surrounds your gut. Those Peyer's patches have a real job to do, and they'll kick inflammation at every turn. PMS, menstrual problems, menopause strategies, essential fatty acids are very important. These are major interference with the yeast syndrome. Yeast puts out a toxin that interferes with the delta-5,6 desaturase enzyme. If you can't desaturate your particular fatty acids, you can't make the omega-3 and omega-6s the way you want to in terms of balance, and you start getting sick with all sorts of hormonal problems. And restore gut function. The smoking guns, lifestyle choices, self-medication, all these things over the counter. I borrowed my sister-in-law's blah, blah, blah. Okay, that was prescribed for your sister-in-law, not you. And then doctor medication. I'll prescribe it for you. And environmental conditions. This planet isn't getting any better. Can we ever really dodge these bullets? I guess that's the question. Roby Mitchell is a good friend of mine. He came up with some wonderful perspectives on yeast. He talked about rosacea. The important thing is that the complement cascade is getting activated. That's kind of the nonspecific activation of the immune system. Well, what's interesting is he keeps seeing that when yeast are present and you amplify this cascade, you get the inflammatory process. He had never seen a patient with rosacea who did not eventually develop arterial plaque. Now we're starting to get down to the basis of disease, which he calls oximation, or inflammation and oxidation, the free radical oxidation. The DNS Pharmacy has a wonderful packet of information. That's dsfarm5 at sbcglobal.net. They have a wonderful packet. I think it's about $35 or $40. And they talk about some of the materials that Dr. Mitchell gathered for them. If you contract one of these diseases of oximation, you're likely to get another. This observation suggests a common denominator in the pathophysiology of all degenerative diseases. Would you consider gum disease to be a degenerative disease? Would you consider dental caries to be a degenerative disease? Would you think that what you're dealing with is one of those diseases, and that you now are faced with a patient who is developing the others? Second set of articles in this packet of information talks about the high glycemic diet. The third set talks about yeast and inflammation. The fourth talks about therapies that have been successful across a wide range of diseases of oxidation. And what's interesting is dark produce and statin drugs are proven antifungals. Statin drugs as an antifungal. What a thought. And then the fifth set of articles talks about thyroid function and mitochondrial dysfunction. Let's talk about Zocor, Lipitor, and Crestor. Their cholesterol-lowering potency matches their antifungal potency. Aspirin is also antifungal. So in clinical trials, the prevention of cardiac events was not correlated with cholesterol lowering, but it is correlated with reduction of inflammation. Interesting. Trans fats cause inflammation. They replace normal phospholipids in the mitochondrial membranes. This hampers ATP production and leads to cell death. Now, guess which microscopic vultures come around when there's cell death? Oh yeah, the fungus, the bacteria, and so on. Here's an interesting thing. Zocor, Lipitor, Crestor with a higher range of an antifungal activity, a suppression of growth. Here's sodium chloride, no suppression of yeast growth. Diflucan, suppression of yeast growth. Beautiful plates that Dr. Mitchell did just for fun. Germacleanse, a wonderful yeast killer. Diflucan. Here's oregano-biotic, okay, in low dose and in high dose. This is compared to diflucan. Remember, oregano is a natural product. Here's electrodyne, that's an activated iodine compared to diflucan. Iodine, that relates to thyroid function. I wonder if you're low on thyroid function, could you be low on iodine? Could you then have more trouble controlling yeast? Now remember that yeast and mold come in different forms, so you must control all of them, not some of them, along with the common cell invading bacteria. In other words, things that would be nice and normal to you now become mean and nasty to you. Sinusitis, which I've already talked about with you as a disease of oxidation, has been proven to have a fungal etiology. This is from Autoimmune Diseases by Davidson and Diamond in the New England Journal. Even in a genetically predisposed person, some trigger, an environmental exposure or a change in the internal environment is usually required for frank autoreactivity. Well, the fungi compromise macrophage function, putting you at risk. Could the yeast syndrome contribute to Alzheimer's? Well, it's become more prominent since the 1950s, and so has Alzheimer's, so has coronary artery disease, among others. Interesting question. Alzheimer's is a progressive disease of inflammation in certain cells in the brain. Inflammation always means on fire. It's the same process responsible as we've looked at for heart disease, diabetes, joint disease, and so on. Inflammation increases with age, making age the number one risk factor for Alzheimer's. You don't see it in young folks. How about if you have diabetes or heart disease, you are more likely to get Alzheimer's? Hormone deficiency, another risk for Alzheimer's. Remember, these are age-associated diseases. Men who are low in testosterone, women who are low in estrogen have a greater risk for Alzheimer's. Deficiency in other hormones, DHEA, thyroid, progesterone, associated with dementia in general. Lack of physical and mental exercise, again, becoming more acidotic instead of alkalotic, amplifying the risk. And diet is always the biggest predictor of inflammation. Patients with inflammatory bowel disease, this talks about interleukin deficient mice. You know what? There's a dysregulation of the immune response to normal enteric microflora in these particular mice. You grow them in a sterile environment, they do not develop their bowel disease. Permeability defect exists prior to the development of mucosal inflammation. It's just the growing of those with bacteria that creates the inflammatory change. They're already predisposed, but they don't get it unless those bacteria assist them with inflammation. Interesting situations with regard to the interleukins and such, because that talks about, like people disease. I have not met a case of Crohn's or any ulcerative colitis that we have not been able to fix by treating for yeast and nutritional support. Macrophages. Every tissue space has specialized macrophages. The liver, you might recall, produces its own little hepatic cells and so on. Well, wherever there's an inflammatory process taking place, different biochemical manifestations will arise, and you'll see changes, for instance, in the liver enzymes, cholesterol, triglycerides, glucose. Wait a minute, ferritin, doesn't this look like we were talking about with metabolic syndrome? Yes, inflammation patterns. This whole show works together. It's not a one-trick pony. Each tissue space has its macrophages. How about adrenal inflammation, resulting in overproduction of androgens and other adrenal hormones, such as cortisol, polycystic ovarian disease, truncal obesity, metabolic syndrome? My goodness, could these things be related to kidney inflammation affecting the macrophages there? Now, how about there's an initial rise in the labyrinths when you have an inflammation in a gland, followed by a deficiency when enough cell damage is done. Patients with diabetes give a history of hypoglycemia. Patients with high blood pressure say, I've always had low. Usually the subclinical thyroiditis that precedes Hashimoto's is missed until thyroid deficiency symptoms ensue. The bottom line, most diseases, especially those chronic degenerative ones, share a common histopathophysiology, inflammation, and if you learn to cure one, you can effectively cure them all. That's why you talk with dentists about something like this, because you can be an important part of that patient getting dramatically better. The Candida exhaustion of the endocrine system is not a single disease. It's the result of differing predisposition factors. Now, patients with Candida endocrinopathies, I'm introducing this new term. Endocrinopathies means they're all screwed up in their hormone systems. They show various disabilities: hypothyroidism, thyroiditis, hypoadrenalism, adrenal exhaustion, diabetes, hepatitis, alopecia, that's baldness. Well, included in these first 9 factors from Dr. Phyllis Safer, a marvelous physician from San Francisco, she later added 17 more endocrinopathies to the list. And she called that the APITCH syndrome, the autoimmune polyendocrinopathy, many endocrine glands in trouble, immune dysregulation, candidiasis, hypersensitivity syndrome. Is that a mouthful or what? APITCH, okay? Here's the others that she added: PMS, Addison's, oophorytis, inflammation of the ovaries, myasthenia gravis, pemphigus, allergic rhinitis, schizophrenia, autism, sprue and celiac sprue. Now, she also added idiopathic thrombocytopenic purpura. Aren't these diseases you've heard there is no treatment for? Aren't these ones where they see doctor after doctor after doctor, year after year after year, drug after drug after drug, and don't ever get better? What about systemic lupus, rheumatoid arthritis, Raynaud's phenomenon, Sjogren's syndrome, Goodpasture's? APITCH stands for a polyendocrinopathy that is totally treatable in most patients. Dr. Safer said all of the above 26 conditions are autoimmune diseases into which antibodies to self can be demonstrated. Why did you get screwy with your defense system? What is it about inflammation and infection that gets in the way? Well, if you go back to Dr. Mitchell, he says, within certain organs, adapted monocytes have special names, like the Kupffer cells in the livers, the microglia in the brain, and the mesangial cells in the kidney, and so on. Phagocytosis is mediated by macrophages and neutrophils. Wait a second, now we're talking about defending ourselves from infection. And indeed, these cells respond to the chemotactic signals in their local environment. So if you change the biochemistry, especially if you have infection changing it, you get all sorts of funny mediators. It includes substances produced by microorganisms as well as by the cells that are participating in the inflammation. In other words, you get worse the worse you get. And things like interleukin-1, which is certainly related to the metabolic syndrome, histamine, there's lots of histamine-associated diseases, which is why we have everybody on antihistamines, and complement activation, which is again part of the introduction of the immune system and inflammation. All of this we're talking about is in the whole bag of worms called the yeast syndrome. How about the acute phase reaction? Everybody's hearing about C-reactive protein, how important that is, because that's a marker for heart disease. Well, you know what? This is the activation of the complement system by the classical pathway. And as C3A is formed and it coats the organisms, that helps to facilitate eating them. You go eating them. C-reactive protein, heart disease. Wonder how much of heart disease is associated with infection, inflammation, and activation of the immune system. It sure looks interesting. Well, Dr. Mitchell says there's a direct correlation between the complexity of a problem and how much you can charge to fix it, according to his plumber. So economically speaking, it makes sense to have a separate etiology for each of these diseases so that you have a specialist with his own complicated reasoning behind why a particular organ is in trouble. Well, except that if you look in the literature, there's 6 degrees of separation that exist between diseases associated with inflammation. And articles highlight the link between depression and osteoporosis. And then those 2 diseases are associated with inflammation and cytokines, but depression is associated with heart disease, and that's associated with diabetes, and that's associated with Alzheimer's, and that's associated with hypertension. And pretty soon you realize we're back to the same ball of wax: inflammation, immune system activation, and infection. Here's a good example from the Health Day News. After a heart attack, patients are up to 4.5 times more likely to develop diabetes compared to the general population. You go, what? One nasty disease leads to another. It's a two-way process. Each is a risk factor for the other, the patient thus potentially being caught in a fatal, vicious circle. Welcome to the yeast syndrome. Yeast is something that just takes advantage of us when we become sick. We become sick because of inflammation and our inability to control, regulate our immune system processes, and this is how it spins. Now remember Suzuki's maxim that in the beginner's mind there are many possibilities, but in the experts there are few. I encourage you as dental experts to become expert in understanding inflammation and the immune system and beginning to realize all these diseases are related to what you are treating in the mouth. Occam's razor says all things being equal, the simplest solution tends to be the right one. And you are looking at the start of the problems that you can easily see right here in the mouth. Seek out the simplest solution that explains the connection to all of these dysfunctions and diseases. This is why a dental history should include a medical history as well. The novice trains until he consistently gets it right. The expert trains until he cannot get it wrong. And my thought with you is that what we're looking at with the yeast syndrome, especially when you look at dental pathology, is you can become so right about what's going on with the other inflammatory diseases in your patients, you cannot get it wrong. You can have tremendous understanding about how it works, way more than other dentists ever would. Orion Truss is the one who, in 1983, published The Missing Diagnosis. It was based on his paper starting in 1978, the first mention in the medical literature of yeast related to inflammatory diseases, and it was from mental and neurologic manifestations he made this diagnosis. Very bright guy. William Crook published The Yeast Connection in 1983. Later it was published by Random House, a major bestseller, a classic for people suffering from yeast-related problem. He was a pediatric allergist. I published The Yeast Syndrome in 1986 with Bantam Books. Still what they call a strong backlister. Keep buying it, folks. If you buy it from the health food store, I do not get my nickel, okay, because they take that out of the author's royalties. But if you buy it from a regular bookstore, I get my nickel. So it's what it is, literally, a nickel. So the Yeast Syndrome book is really wonderful in terms of explaining this, very similar to the way I did it right now. And then the final question I really have to ask is, are we losing the battle of degenerative diseases? Well, you know, based on this lecture and the one I just presented, the question really comes down to how many doctors do you know who are actually treating the yeast syndrome? That's a very disturbing answer because it's very few. Thank you. You've been a wonderful audience. Thank you so very much.